Thank you, Miriam. I have to admit, when I was putting my slides together, I was very nostalgic thinking about how quickly 2 years goes by and how much I've appreciated the opportunity to be part of this transdisciplinary fellowship. Today I'm going to talk about little brain health in preterm babies, and that's not some lazy pun, but I'm actually borrowing from the Latin for cerebellum, which is a structure at the back of the brain that translates into little brain. As a child neurologist, I became interested in prematurity because preterm infants have a high risk of disability. More than 50% of preterm infants have motor, cognitive, behavioral, and social deficits. This number is even higher when we focus on the youngest and the sickest babies, and when we follow these infants into adolescence, where we can test for subtler cognitive challenges and executive dysfunction. And over the past couple of decades, we've made gains in survival after preterm birth, particularly in high-income countries. But we haven't made similar gains in long-term outcomes. So I think it's absolutely critical that we continue to think about ways in which we can protect the preterm brain and promote improved neurodevelopmental outcomes. A lot happens between being born early and reaching term age. I know I'm biased, but I would argue that what happens in the brain is absolutely the coolest. These are serial MRI scans showing a preterm baby at 28 weeks and again at 40 weeks postmenstrual age. And you can see that the brain at 28 weeks is almost entirely smooth. There's none of the folding that really gives rise to the eloquence of our brain function. All of that takes place while we care for babies in the NICU. And during this period of time, the brain is highly vulnerable to injury. For a long while, much of our focus has been on injury to the developing white matter. White matter injury is considered to be the dominant pattern of brain injury in preterm infants, consisting of a spectrum of both cystic and non-cystic injury. Ultrasound's great for detecting the most severe forms, cystic white matter injury, but using MRI scans to study preterm babies, we've been able to visualize the milder end of the spectrum. Over time, though, white matter injury has declined. Several groups have shown a reduction in cystic white matter injury, and more recently, we also showed that non-cystic white matter injury is similarly decreasing. And I think this leads to a really important question. If white matter injury is the dominant pattern of brain injury in preterm infants, and it's declining, why haven't we seen a commensurate gain in long-term outcomes? And to answer that question, I think we need to shift our gaze away from the white matter and focus on the cerebellum, a structure that, compared to any other structure in the brain, disproportionately undergoes the greatest degree of volumetric growth and surface area expansion during the third trimester. And moreover, growth of the cerebellum and development of the cerebellar cortex continues throughout the first year of life. And during this period of time, the cerebellum is also highly vulnerable to disruptions in this regulated, programmed course of development. And it turns out the cerebellum is involved in a lot more than motor coordination, as it was long thought to be exclusively responsible for. And more recent data has shown us that the cerebellum is involved in a lot of higher order cognitive tasks, affective processing, language, working memory, executive function, all areas that are quite impacted in children that were born preterm. My own interest in the cerebellum traces back to one of the first patients I saw doing my neonatal neurology fellowship at UCSF. And this was a baby that was born at 28 weeks, and he was enrolled in our preterm imaging study, and he had this MRI scan at 2 weeks of life, which showed these dark areas in the hemispheres of the cerebellum, representing areas of hemorrhage. And when I saw the scan, I was quite fascinated because I'd never seen this pattern of injury before, and I looked to the literature, but there was very limited information out there. I kind of found myself in a bind as to how I could explain to this family what caused this injury or what it meant for their child. And that really became the impetus for my fellowship research project, in which I aimed to evaluate the clinical predictors of cerebellar hemorrhage detected by MRI, as well as secondarily evaluate the impact of cerebellar hemorrhage on growth of the cerebellum. And to do this, we leveraged a prospective imaging cohort that my mentors have had since 1998. And in this cohort, babies that are less than 33 weeks at birth are scanned with MRI as soon after birth as clinically feasible, and again near term age or discharge when possible. And for this study, we focused on babies enrolled after 2011 because we changed our imaging technology to a more sensitive magnet and different imaging sequences. Working with Jim Barkovich from neuroradiology, we reviewed all of the MRI scans, scored them blinded to the clinical history as to whether cerebellar hemorrhage was present, how many spots were there, how big were they, and where in the cerebellum did they occur. And of the 73 patients that were available for this study, 27 had cerebellar hemorrhage. So a rate of 37% was much higher than the rate of non-cystic white matter injury or intraventricular hemorrhage in this cohort. And we went on to look at a number of different predictors and found that a variety of things predicted an increased risk: lower birth weight, intubation at birth, prolonged ventilation, hypotension, patent ductus arteriosus. They all increased the risk. And we interestingly found that antenatal exposure to magnesium sulfate was associated with a decreased risk, regardless of whether it was given to women for an obstetric indication or a neuroprotective indication. And when we adjusted for all of these factors, we found that magnesium sulfate was independently associated with an 82% reduction in the odds of cerebellar hemorrhage, which translates into a number needed to treat of 3.2. In a subset of these babies, we went on to study the quantitative impact of cerebellar hemorrhage on the growth of the cerebellum. And to do this, we used cerebellar volumetrics, and I worked with a very bright mathematician named Ho-Sung Kim, who was a postdoctoral scholar at the time. And we manually segmented out the cerebellum and traced its butterfly shape on a number of scans. And we were able to show that cerebellar hemorrhage mapped to very superficial areas of the cortex of the cerebellum. And we could further see that the areas with the greatest density of cerebellar hemorrhage were the areas in which there was the greatest degree of volume loss. It was the high rate of cerebellar hemorrhage in our cohort that actually caught the attention of the editors and was the focus of the accompanying editorial with our paper. Our rate was 2 to 3-fold higher compared to other studies. It's an open-ended question as to whether this is a reflection of cerebellar hemorrhage being more common, whether we're getting better at detecting it, or maybe there's something different about our babies at UCSF. But I would argue that I think we're just getting better at finding it. We used very thin cuts through the cerebellum that were 1 millimeter in thickness, and there were no gaps in between. In addition, we used iron-sensitive sequences that can detect very tiny areas of hemorrhage, and ultimately we could discriminate hemorrhages as small as 1 to 2 millimeters. So this data absolutely supports the importance of continued research into the long-term impact of cerebellar hemorrhages in preterm infants, and that's something that is ongoing as part of an international multi-center cohort study, and through a nascent collaboration I have with colleagues from psychiatry, psychology, engineering, and radiology to see whether these areas of hemorrhage increase the risk for abnormal social cognition as a prelude to autism, which is also increased in preterm babies and could potentially be explained by cerebellar injury. What was much more interesting to me, though, was this association with magnesium sulfate. Mag sulfate was initially observed to potentially be neuroprotective based on case reports in the 90s, and babies that were born to women that had received magnesium sulfate for preeclampsia had a decreased risk of cerebral palsy, which is a non-progressive form of motor disability. That led to randomized controlled trials in the 2000s where they looked at an exclusive neuroprotective indication of mag sulfate in women less than 32 weeks gestation that were presenting with preterm labor. And it proved to be effective. Meta-analyses confirmed pooled findings of these studies that CP, as well as substantial gross motor disability, were decreased in babies that were exposed to magnesium sulfate. But what none of these studies were able to show was why it might have worked. Mag sulfate wasn't associated with a reduction of brain injuries known to cause CP, such as cystic white matter injury or IVH. And though these studies were limited by use of ultrasound as opposed to MRI, and so we think our data may be starting to fill this gap. And we hypothesize that some of the neuroprotective effects of magnesium sulfate may be mediated, at least in part, through a reduction of cerebellar hemorrhage. Subsequent to the publication of these trials, there were a number of professional bodies that endorsed use of magnesium sulfate, ACOG, the WHO, to varying degrees of enthusiasm. But uptake since then has varied considerably worldwide. And I think this points to a really important opportunity to increase administration of a safe and cost-effective medication in order to improve long-term outcomes in this population. And I had the amazing opportunity to go to the PTBi symposium in Nairobi this past fall and present this data. And it was there that I recognized I should still definitely sit in the front row for class pictures. But more than that, I realized that continuing to pursue the implementation barriers to magnesium sulfate was something I was really passionate about. And it began to occur to me that while barriers to magnesium implementation vary from place to place, we always talk about the place-based context in the PTBi, there's a critical barrier that affects a variety of settings, which is the inability to administer an intravenous infusion 4 hours prior to delivery. The reasons for which will vary based on the place, whether it's capacity, availability of equipment or personnel, or a time constraint. And in order to laterally circumvent this barrier, I wondered whether we could just use an alternative formulation to magnesium sulfate, as opposed to giving it IV, whether we could inject it in the muscle, which is used in other medical contexts, and deliver it to the mom and consequently the baby more proximate to delivery. And I'm really excited to have the chance to continue collaborating with the PTBi and working with the postnatal intervention team, with Linda and Liz, to begin to explore how we might be able to study this as a comparative effectiveness trial. And so to do so, we're starting a preliminary phase of community stakeholder engagement. We're developing an advisory board with representation from maternal fetal medicine, labor and delivery nursing, pharmacy, neonatology, women who have received magnesium sulfate, to see whether this is a good idea to move forward with, and if so, how we ought to do this in a way that makes the most sense. And I very much hope we can scale this up into a local trial in California and eventually take it to a trial in East Africa, because there's absolutely zero data about neuroprotection in low and middle income countries. And I was at an international meeting for CP research in the fall that many people from PTBi were at. And I think it was very clear by consensus that this is a huge research priority to the research community, but also the families. I would be remiss if I didn't kind of reflect on some of the highlights of the past couple of years. Being a part of a transdisciplinary cohort was just an incredible experience to hear so much about people's research in fields so very different from my own, and to have that reciprocal input as we developed our projects, looked at our data, thought about how it all fit together. It's really broadened my perspective. It's cross-pollinated ideas, much in the way that I think the collaboratories do, which have also been just a great source of food for thought and discussion over the past couple of years. So I thought I'd end with a slide that I include in every talk I give, but I wanted to show you how this has changed for me after 2 years in the PTBi. And while I've always been very focused on this period of brain development during the 3rd trimester, I'm now seeing it in the much broader context. And I'm thinking so much more about how the social and environmental determinants of health that intersect to give rise to an increased risk of prematurity are also factors that are independently associated with adverse neurodevelopment, regardless of whether a baby's born preterm. And so I think that as I continue to try and build a career focused on improving long-term outcomes in the preterm population, I need to keep this big picture in mind and focus not just on what happens while we care for babies in the NICU, but the factors that occur upstream to preterm birth and downstream from discharge. So I have a lot of people to thank, my mentors, Donna and Jim, all of my colleagues and collaborators who make our imaging research possible, and like everybody in the PTBi, but a special shout out to the people that were really involved in the fellowship, my co-fellows, Miriam for her leadership, Jonathan and Monica, who really took good care of us in the first year, Aaliyah, Saika, and Nicole, who have been very supportive of us as a group as well. Thank you.